I'm Linda Regan. I'm from Johns Hopkins. This is Jeremy Branzetti. He's from NYU. We have Mike Gisondi, Mike wave down there, he's from Stanford, and Laura Hopson, she's from University of Michigan. And we're happy to be here today to talk to you about a topic that we've become really interested in and passionate about, which is competency-based medical education, what it is. Most of you know that, but the nitty-gritty a little bit about why it was developed and what types of problems it's created for us and some of our learners. So our objectives are here. We're going to go through in about 15 minutes some basics, and then we're going to spend the remainder of our time talking through some case scenarios of some issues that we feel really have become problems in the model of CBME for us as educators and for our learners. And we're hoping that everyone will help us work together to sort of crowdsource some solutions that you'll be able to take back to your programs or your places to deal with some of these issues. We're going to work on putting a document together, which we'll go over later to give you some instructions on how to do that. So for clarity's sake, I think it's important to recognize that the traditional model of medical education in the past was a model where the curriculum drove the learning process. And the model of competency-based education, curriculum is not the driver of learning, which seems sort of funny, but the driver of learning is the health needs of society. And this idea that the person that you need to be able to meet the needs of society, you need to know who that person is, and you need to know what skills and abilities that person needs, and then that drives the outcomes of what you're trying to create. And once you know who you're trying to build, then you can build your curriculum and you can build your assessment to assess whether or not you've actually built that person. So what does this mean for medical education? It means that there's a much higher focus on actual accountability, where regulatory bodies and society are sort of paying attention to make sure that the person that's the outcome, our residency graduate, is the person, thank you, that we're producing. I'm going to just put that over there. And that means that we have very specific criteria, things such as the milestones and EPAs that help guide our ability to say that we've produced the right type of person. So for clarity's sake, I think it's important that we're all on the same page. So if you take all these mesh terms and put a search in, you get over 100,000 articles that are linked to mesh terms related to competency or competency-based assessment. So we want to take a second and make sure we're all on the same page about what these definitions are, because understanding truly the difference between competence and competency and competency-based assessment will actually help us uncover, I think, why we are in the situation that we're in. So what is competence? Competence is defined as an array of abilities across multiple domains or aspects of physician performance in a certain context. All that is to say, this is I think we all know, right? Competence is, can you do it? Do you have the knowledge to do it? Do you have the ability to do it? And competence, excuse me, competence is dynamic. So while based on experience, based on time, based on the environment that you're in, you may be competent in one environment, for instance, a resident in the adult emergency department taking care of a patient with DKA, whereas you may be incompetent in another environment, such as the pediatric emergency department, where they've never had an experience of managing fluid in a patient of a different age because the rules are different. And so competence will change based on where you are. I think this is all probably very familiar to people, Miller's pyramid, with the recognition that we all make the assumption that the low basic level of competence, the ability to know something, is at the bottom. That's where we start. At the top, we think the advanced level is the fact that someone can do something, all right? And the reason that's important is because competency, the definition is an observable ability of a health professional that integrates multiple components of knowledge, skills, values, attitudes. All right, the key word here in this definition is that it is observable. And why is that a problem? That's a problem because we can only see certain things. We can see what people do. We can hear them when they speak to us and make assessments about their knowledge based on what they say. But I think we all can understand that it might be possible that someone can do something and look as though they actually met our criteria for competency, but actually don't have competence. All right, so take an example of a resident who's ordering a medication in the electronic medical record, and you're looking to determine whether or not they have competency in choosing the right drug. Well, they have an order set that provides them 3 choices, and so they might select that medication appropriately, and you say, yes, they have competency in this, they selected the right medication. But if you ask them why they chose that medication, they actually don't have the knowledge behind that. So there can be a disconnect, and this is sort of part of the problem as we look at things being observable to say that that is meeting the criteria of competence. So competency-based medical education It's an outcomes-based approach that's focused on designing, implementing, assessing, and evaluating programs that are organized based on competencies. So you all know our competencies in medical education. They're the core competencies: patient care, interpersonal and communication skills, systems-based practice, right? So we all are, I think, pretty familiar with those. And the recognition that this system is based on 4 main principles. Number 1 is that it is taking a focus and saying, you know what, we're really interested in the outcome, the person we're producing, because remember, CBME is focused on accountability to the public and society. It's saying we want to decrease emphasis on just knowledge, and we want to increase emphasis on what that person's abilities actually are, and that we can see those abilities. It's decreasing a focus on time-based training, and I think we all know this, but no one really does this. So this is supposed to mean that your learners don't need to graduate in 3 years or 4 years, because if they haven't developed the abilities that you need, or the outcome that we're looking for is not met, they should still stay in your program. And the last principle of CBME is an increase in focus on the learner. And what they mean by this, which it wasn't clear to me when I was initially reading some of this work, what they mean is that by providing things like milestones, by showing our trainees what we want them to be able to do, we are supposed to be encouraging their own participation in their learning by saying, you know what, I don't know how to do that yet. I should be taking responsibility for changing my learning or modifying my learning plan because I have clear understanding of the transparent goal at the end. And so what this means is that CBME really wants this goal of sort of special snowflakes, right? Everyone should progress at their own pace with when they are ready to graduate, they will graduate. I think it's clear that that is not what has happened in medical education in the United States. Even though this was the goal of CBME, we're still very tied to our training formats in terms of the number of years we have residents. And lastly, just to point out that this is what the ACGME is telling us, right? Their goal, when you look and read in their information, is that the intended output of CB programs are professionals who can practice medicine at a level that we want them to meet the needs of our society. And what that means is as society changes, our desired output of who we're producing may actually change over time, and that we're looking at assessments that are specifically being made to target whether or not our trainees have met a specific competency. All right, so that's the landscape that we're in. I'm going to turn it over to Jeremy to talk about some of the problems.
So Linda has laid forth the underlying tenets of where CBME came from and has started to show where some of the cracks come forth. And thusly, this was a well-laid plan, but as Frost had said, excuse me, as Burns had said, the best laid plans of mice and men will often go astray. We want to talk, there are a number of great critiques out there, and the literature in this is actually fascinating to read, particularly even the literature about the literature of this, but functionally we're going to talk about 3 specific things here. The reductionism is a system that CBME depends on for assessment driving. One, what are the effects of this externally driven assessment mechanism? And then just the sheer practicality of faculty resource demands of what CBME predicts would be necessary for success. So let's take a moment and go through each of them. Reductionism is this concept where you can take a complex phenomenon and break it down into constituent discrete parts to then measure, explain, and those parts come together to then capture that phenomenon. This can lead to a sort of idea that 2 things. One is that the outcome, what you measure, winds up being very important, but then secondly, do we capture all that of a physician from breaking up into small parts? And I'm not sure that we do. If we really look at the idea that we now set forth, we're going to judge or we're going to set our eggs in the basket of assessment of what somebody demonstrates, then we have now taken a focus on the outcome and not how one got there. And Linda alluded to this in a number of ways, but this is sort of a flip of the Emerson quote of, you know, life is about the journey, not the destination, but now we're saying it is the destination. What you have shown, as long as you can show it, that's what matters. And we have, if we adopt this system without having a recognition of this potential risk, we could potentially cast aside how people got there. And this can manifest in very unfortunate ways. If we just say that your score on an in-service, show me you can achieve this level and we're fine, we ignore how they got there. Was that an epic couple of days of cramming? Or was that a series of reliable and appropriate study methods that taught them lifelong learning skills that will pay off for their career? When we ignore that, then the outcome is what we see. So the problem winds up being, if you look at this destination, then you ignore what's going on around you and the development that happens therein. And if we do that, that comes at great peril at some of these things that we can't easily define in a competence system. How do we define how one grows their sense of resilience? How do we define their ability to be self-sacrificing for the need of the patient? If it's the outcome, we don't necessarily see how they develop and how they get there. But the other part of this, really, of this problem of reductionism is, can you break a physician or all of the tasks physicians do into certain parts that then capture the whole? And there's some good data actually at the outset of the CBME movement in medicine that suggests maybe we can. In this study by Hodges, you take 14 med students, 14 residents, 14 attendings, and say, we're going to put you through an OSCE, go do this H&P. Very standard, very common at all of our schools these days. If you assess them in a global sense, where you just look at them holistically and say, did they succeed at this, and who scores the highest, faculty win, hands down. But if you checklist them and you break down each of the parts of what they determined of a H&P and a diagnostic OSCE should be, the faculty fail. They wouldn't have made it out of med school. And the difference showing that perhaps the parts really don't capture the whole. And maybe that may be an issue of this one OSCE. It's not the right parts, but it certainly shows the risk of what may happen here. If we are focused on breaking things into small, we see the trees but not the forest. The second issue here, once we've established that reductionism can lead to this problem of focusing too much on assessment, well, then it becomes the problem of whose assessment and are we picking the right ones. Externally driven assessment is the idea that if we are setting forth all of the criterion which people have to then satisfy, our students, our residents are going to satisfy them. They are high achieving learners. They've done this their whole life. But they're satisfying what we tell them instead of what they are starting to realize is the important process of learning. So just take for a moment just the importance. We don't want to cast aside assessment as a valuable modality. If you have a program, you need to have standards. You need to be able to show something. I think the question is, what is it that you pick to assess? And have we inadvertently focused on the wrong things? When Socrates had described this, and many of us get this as educators, a mind is not a vessel that needs filling, it's kindling that needs igniting. So fundamentally, as educators, we are not here to spray a fire hose of content and have it be absorbed on our learners. We should be motivating them. We should be teaching them to get to that point of that spark that says, oh man, I never thought of that, or oh, that's really interesting, I'm going to go look that up. That's how they learn, not from sitting in conference, not from what we teach them at conference directly. But the question is, do we really do that? If we were to really ask honestly, is our med school about motivation to learn, and arguably even parts of residency, I would say, if we take a hard look in the mirror, not really. What are the assessments we choose? What are the things that we're looking at? Is it reflection? Is it the ability to admit one's mistakes and show how one grows? Is it showing your critical thinking? Is it any of these methods that show the process? No, it's step one scores, it's slow evaluations, it's MS3 grades. So if you ask a med student, if we ask our MSAs, a candid question of what is the biggest goal you get out of med school, it's getting into residency. It's not the skills of being a good lifelong learner. It's not the skills of being a good doctor. Sure, you learn those along the way, and over time that's going to be part of it, but factually, it is the process of competing to get to the next step. So we may be disincentivizing, and there's actually, similarly, a number of points of literature that show students who come into medical school have high-end self-directed learning skills, and then we quash that after the first year, and it just stays low after that because of the way that we've designed our system. So this leads to then further outcomes. If we then set a bar, our residents will meet that bar. With few exceptions, they're going to do that, and we've learned that. We learned the pleasant fact of sometimes we set that bar higher, and to our much great joy, they meet that bar. But the problem winds up being if we set this binary, this set outcome, then there's a finish line. So instead of the process of learning, it is now, I have checked off your box. Do I have to learn more? And if we don't teach them that this is a continuous cycle, this is a thing that must go on beyond just this competence certification, then the learning stops. And this can be shown in a number of good studies about this, about how people learn to continue after residency or if they plateau and hold there. So the final critique here is just really a pretty straightforward brass tacks logistics one. Faculty resource demands in a system where if you want to define everything that we're going to assess, and then we are going to build assessments for every one of those things, and then accurately and efficiently and reliably assess them, you can see the almost permutation-like exponential growth of the number of correct assessments and effort that will take to do that. So the logistics of this are a difficulty if we adopt it wholesale, as it's said. As Linda pointed out, a curriculum used to be what drove learning, and it was a bit of a secret sauce of time and struggle that would happen there, and for the most part it worked, but there were a number of glaring examples where it didn't, and we had to up we had to meet our our duty to society to start demonstrating things. So if we have to do an assessment for every competency outcome, then we're going to have to train our faculty. How much time, for those of you who are faculty or clerkship directors, how much time do you have in your faculty meetings to be able to do faculty development on an assessment you want to do, or to train people on how to more reliably catch this skill or to give good feedback on this skill? Minutes at best. And we try our best, and understandably because our department has many other initiatives they have to deal with. But, I mean, who remembers trying to explain milestones to their faculty the first time, right? First the language, then what these numbers were, and what wound up happening. Inevitably, I guarantee you, all of you had assessments that looked like this. This is one of my interns in October of intern year, and you can just see here on the first 4 patient care milestones, they're already getting a grade of a 3 of their average, but if you look at their max, they are racking 4 points, 4.5s and 5s. Because people just don't, it's not an intuitive system, and the amount of development you need to accurately get a good assessment to then give them feedback is a large amount. This is not easy, and this requires a lot of development, and just the sheer logistics of a full-out CBME system is a challenge. And then I mean, I don't even want to get started on these two. I'm sure most people use one of these in the room, and I don't think it necessarily helps your job so much as it hinders your job. So really, the assessment background and the logistics are yet another hurdle to this system. So those are the 3 concepts. Reductionism: do we capture the whole by the sum of the parts? Are we disincentivizing the learners to be self-directed by having externally driven assessments and not teaching them the value of why you're meeting this level? And are the faculty demands of a wholesale CBME system just too much to be able to meet? And with that, I'll turn it over to Mike.
Good morning.
Hopefully, if you need to, let me know.
We'll just advance forward.
Yeah.
Oh.
So we're going to try to make this very practical. Very theoretical, just a quick review of CBME and some of its major challenges. 20 minutes for the market. We're just in the next 30 minutes, so working through 3 cases, 10 minutes each, all related to GME, other cases, for those who are in the audience. So you have
I think so. Oh, sorry, there we go.
this bit link to the bottom, or scan that QR code. It's going to take 2 minutes to let you open your devices and get on that Google Doc.
So if you don't know, for most of you, if you have any relatively new updated phone, if you just pick up your camera and aim at the screen, the QR code will lead to a link automatically on the screen. Laura. Do you have the handheld?
Okay, yeah, that's much better. We'll go from here. So, you're going to see a Google Doc. The first portion of that Google Doc is going to be an area where you can put your name and email address. We're going to summarize all of the comments in a nice, tight handout at the end of this process and send them out in about 2 weeks to anyone who would like them. So if you'd like to contribute and then also get the results sent to you, you can go ahead and put your name and email address at the top of the Google Doc. Andy King, go to that website. Welcome. All right, we're going to go through 3 cases. Whoop, did we lose? Here we go. I see some people still trying to QR. I went back for you. There you go. All right, everyone's got what they, oh, I see one more. I see one more. That's right. Laura's going to take some notes for us as well as we talk. So we have 2 medical student ambassadors with us. We're going to work the audience and come around with microphones so that you can contribute to these cases. You could also type the address in using the bit.ly. You don't necessarily need to use the QR code. So let's go to case 1. This is a PGY2 resident, and the nurses and the attendings keep coming up to you as the program director and telling you that this resident just isn't very good. They're not as good as their classmates, and that you need to do something about it. All the program directors in the room, have you heard this before? Pulled aside in the hallway. This resident just isn't as good as the rest of the residents, right? So you look at their evaluations and you try to get a diagnosis for this particular resident, and you realize from the last 6 months, all of the comments really are on par with expectations and are on par with the average for their class. So let me share just a couple of those evaluation comments. Back in February, there was a comment from a faculty member. This is a pretty good piece of feedback. Good fund of knowledge, good at task switching, prioritization, fun to work with. Continue working on active listening, patient reassessments. You are on target for your training, and I'm looking forward to more shifts together. There's nothing negative there. You don't get that sense of that they're just not as good as their classmates. In April, great resident, thoughtful about patients. Perhaps that's not very formative. May 7th, as with most first-year residents, this is actually second year, she could benefit from reading more on each patient and examining as many normal and ill pediatric patients as possible. And on May 8th, a pleasure to work with, responsive to feedback. So what do? We want to hear from you. You've thought about this concept, particularly of reductionism. You've heard a little bit of the theory about CBME. Let's apply that as you think through how do you respond to these hallway conversations. And they're increasing. Every time you go to work, one of the nurses or the faculty members are saying, this resident's just not as good as their classmates. What ideas do you have? We're in a safe and healthy learning environment, everybody. Hey, Carrie.
Hi, Mike. I start with more data collection at this point. I take whatever the specific comments are and I expand that out to talking to other people. I maybe use targeted questioning of their classmates to see if, not about the resident, but about each individual's own particular knowledge and thoughts on this deficiency and whether they fulfill that deficiency, to see if the target person is actually really behind their peers in this situation. But mostly I still feel like I'm in data gathering on my end, and what I do in the conversation with the person who's coming to me with the complaint is say, well, did you talk to the resident about it? I mean, like, this is your job too, so if you haven't addressed this with them yourself and your concerns about their deficiency, whatever it is, then you're not doing your job. You're not part of the solution.
Yeah, exactly. I see some of my old residents here from when I was a program director. I got tired by the end of a 7-year run of people pulling me aside in the hallway, and I would say, you know, if you don't write it down on the computer, it didn't happen either, right? So you have to assess this person and give me something concrete that I can then sit with them, collate, find a theme, do a thematic analysis, give them a diagnosis as a learner, and give them an action plan. Without that first piece of assessment data, I can't do all of the other steps. That's exactly right. Doug.
As chair of the CCC, something I've done on occasion when, after this hallway conversation is actually pull up these evaluations and show them, like, as far as I can tell, this resident is doing fine.
Exactly.
And I need some data to really work with.
Yep. I hope you're typing ideas on the Google Doc if you're not raising your hand, but other comments, other ideas? That's all right, you can type. We're encouraging you to use your devices.
It wasn't me. Sorry, thank you. It was the program director before me when I was the APD, but we switched to a daily end of shift evaluation, and it's just 2 open text boxes, areas of strength on this shift, and then areas for improvement. And then there's also the private program director comments that can get sent to me, which happens maybe once a quarter. Now, we still get a lot of the positives, like great job today, blah, blah, blah. And then when it comes to providing the negative feedback, it's still no issues noted the shift and stuff like that. But at least some commentary is better than none.
No, I agree with you. I think When you're starting to find these residents, perhaps your evaluation system is failing you, and that particular resident, whether they're pre-probation or on remediation or they're on probation, they perhaps need their own version of an assessment tool. And I've several times over the years created a separate assessment. I've tried to figure out what the main issues are from the hallway conversations, made questions about those, and then made promotion decision questions at the bottom of each one. So a question, can this resident advance to the third year, yes or no? And then those residents need to go every shift to their attending with a special SurveyMonkey link and say, can you please fill this out? This is separate and different than my normal assessment tools. And I'm in a place where I really need to be working on certain skills. And they can talk about what those skills are at the beginning of the shift. They can share the link at the end of the shift. But sometimes your assessment system is failing. Those one or two students are getting through the process with just kind of generic comments that are, reductionism, right? They can do a couple of things, but their overall performance as a physician perhaps is still subpar. I like that comment a lot.
I think one of the key elements that if you look back at the literature on identification of the problem resident, and I'm currently blanking on the lead author, it's a roughly 2005 study, I think it's Y-E-E, but I wouldn't swear to it. But one of the elements that comes out nicely in there is that very often this sort of informal, oh, by the way, conversation in the hallway is one of the key mechanisms by which individuals who are struggling for whichever reason are actually identified. So they focus principally on internal medicine residents in this study, and it was the casual curbside and the chief residents who really identified the people struggling. So the key thing here, though, is not to disregard this informal information conduit and say, well, it's not in the formal assessment metrics, so there can't be a problem.
One of the comments is about scheduling a direct observation. Who might have put that on there? Anyone want to speak about that briefly? So to schedule direct observation with the resident?
I think if you work in an institution where you can't trust that your faculty give honest evaluations because of retaliatory concerns, then you just need to verify it yourself.
That's a very good point. Yeah, I think there are faculty who are just, they're reticent to write down what they really believe. Some of the systems, the system that we have at Stanford, Kimberly's at Stanford with me, you fill out a MedHub evaluation, the resident gets it immediately. The middle of the shift, I'll fill an evaluation out, the resident's getting that evaluation. There's no time delay whatsoever. So it's really difficult to decide, when am I going to give this perhaps difficult piece of feedback? Do I do I type it at the end of the shift and they go home and read it before they go to bed? Do I do it the next day when they have had a little sleep and a little bit of distance from those cases? It's difficult. It's difficult. Nunu.
I know you said to take off the UME hat, but it's
No,
a little
yeah.
harder. Mine's more of a question.
Sure.
In general, it's what is the thought on having some sort of a 360, like maybe having nurses who more routinely and more regularly observe the house staff to participate in the evaluation process?
No, absolutely. This is one of the premises of CBME. If in the most recent literature on CBME, there's several principles by which you institute a CBME curriculum and you institute CBA, competency-based assessment. One of them is multi-source feedback. And I know we talk about multi-source feedback constantly in this new milestone era, and it's difficult to do, right? Are we going to get sources of feedback for every single anchor of a milestone on every single subcompetency? It's tough. We try, with clinical evaluations, with simulation evaluations, with CCC evaluations, but I think what you're getting at is separate evaluations for all of the people who can see them in the clinical unit and getting information from a whole bunch of different directions for that particular diagnosis to be made, that learner diagnosis to be made. And I think that's very important. All right, let's move on to our next case. This is a third-year resident in your program. And this is a smart resident. This is one of those kind of savvy residents that can get through doing just what they need to do, this external driven assessment. So feedback discussion with a resident at a semi-annual about how they can be a better team player amongst their colleagues. This particular resident never swaps shifts with ill residents. They won't pick up shifts when a classmate is sick or needs coverage. They'll sign out work at the end of the shift without completing their assignments, right? You've never had this resident in your program, right? Never had this person. So when you sit down and give them the feedback, they say, well, which milestone is linked to teamwork, right? And if that's a common question on a new employer evaluation, then that might be a reason that I would be a better team player. But if the new employers don't ask about teamwork and covering shifts and those things, well, then why do I need to do it, right? There's no milestone. There's no employer assessment of this. So why do I need to complete my work before I go home? Why do I need to swap shifts? Why do I need to be a good team player? And they point out to you they did really great on their in-training exam, and the comments on their evaluations are always really good. And you told me assessment drives learning, program director, and if we're not assessing this teamwork topic, then why should I be worrying about it? I can think of a couple of instances in my 14 years in program director life that I had a couple of residents that were just like this. And they're very smart. They're very savvy. They can get through the system. They know all of the external metrics to be able to meet. Yet, when you try to put it together, they're just not as professional. They're just not as engaged in their class as all of their classmates are. How do you give them that feedback?
Seemed to be much tougher based on the amount of comments.
Is it a problem at all? This is your mid-year feedback. You're saying, you know, my observation is all of your classmates are quite engaged. They come to all the resident activities. They participate. You don't. You go home at the end of your shift. They identify you as the one who'll never switch a shift, who'll never give away their time. Yeah.
So I think what you just said actually is two separate issues for me. I'm the program director at a fairly new program in the Southeast. If they're not coming to resident activities, then that I think is something that we as program directors can, and punish isn't the right word, can remediate. I mean, if we have required things that they're not meeting, then they're not meeting their trajectory towards graduation.
Sure.
So if we actually have
the picture that it's not a required thing. They come
Okay.
to Journal Club, but perhaps they don't come to the social nights.
Okay. And I think what I would do in that situation is tell them, listen, you're absolutely right. I mean, you are doing all the things you need to graduate. However, you know, you are also creating a reputation for yourself that you're going to need to own. And when you go out and join a group practice, you are going to be identified as the person, and I'll be very frank, you are a person who is not a team player. You are not going to have people that want to help you out because you don't help them out. You know, medicine, emergency medicine is a specialty where we have to have each other's back. The things are difficult, you know, family emergencies happen, and if this is how you choose to live out your career, you are going to have a very difficult time being successful. And put it on them. It may not be a remediable personality flaw. This may just be who they are. And if they've gotten this far in life with this strategy, then it's obviously been successful for them to some degree because, I mean, they're most of the way to graduating residency. They've got a doctorate. They've graduated college. So they've developed a skill set to get the things that they want. I would just put it on them and, you know, tell them this is the path that you're creating for yourself.
Now, what if this resident responds to you that they really just, they didn't understand that expectation? Right? Have we not set up a world where we can truly provide at orientation all of the soft expectations of the hidden curriculum, right? This is a professionalism, hidden curriculum expectation that perhaps they just didn't know the rules of the game. And now, if we're talking about measuring things, we're in competency-based assessment, we're going for multimodal assessments. How do we really know this is a problem? Have we measured it? Have we given them an expectation? Have we measured it? Do we need to give them an expectation? Do we need to measure it? Most people figure it out, but some people don't.
And we're not penalizing them for it, right? So we're not saying, yeah, this was a secret expectation that you didn't meet, and as a result, you're being penalized, right? Mm-hmm. I'm not saying you can't graduate. I would then say, well, this is part of professionalism for what we do. From this point forward, become more thoughtful about it. Take this and move forward in your career. Again, this, you know, they're not being fired. They're not being punched in the throat as much as we'd like to during this conversation, right?
Right.
But, you know, I would say you have chosen to be a professional. You have chosen to take on this level of responsibility that is more than just clocking in 9 to 5 at a desk job. And with that is incumbent upon you the responsibility to be a professional with good interpersonal relationships. Take that and move forward with it.
I like that. Other comments? Yeah.
Thanks. Sometimes we're assuming a premise here that the resident's a jerk. And I think it's worthwhile to explore what's going on in this resident's life that may really constrict what they do in their residency. Do they have other family obligations? Are they taking care of a sick person? Do they have some health issues that they need to really pay attention to? Do they feel the world is against them and they may have like some psych limitations? So I would actually start this issue there. Is there something deep in the background that we don't understand? Although I like that other comment too. Once it just seems like they are a jerk, then point out what the limitations in their careers are.
I 100% agree with you, right? We always have to begin with, are you okay? With every negative instance. But, you know, a lot of times you get past, are you okay? And they're fine. And perhaps, you know, now the question is, are they a jerk? Or do they, you know, really just have a different view of work life? You know, I do think that we encounter some residents who believe that they have entered a specialty where they clock in and clock out, and this is the expectation. They chose the specialty for a reason. Perhaps we have to bring them along and tell them what the professionalization of our specialty has become, but they really just have a worldview that's different. And I think you're right. So, you know, they may not be a jerk, they may not have anything wrong with them, but they may think that this is totally normal. And I worry that in a world of competency-based assessment, we have to be very deliberate in what we think our expectations are so that we can give people feedback that is authentic and not conjecture. Yeah, but I agree with you. They may not be a jerk. You're right. We have to come from that premise.
Yeah, I think that this is the kind of behavior that they might get away with for a little period of time, like during residency. It's a 1 year, 1 year, 1 year. And people may be a little upset about it, may feel they're not being team players, but they're willing to let it go because they know there's a finite end to it. Whereas when they get out and start working in the community, in whatever setting, then they're signing up for a long haul, and people are going to start noticing that that behavior isn't so good, especially things like bad sign-outs at the end of a shift, incomplete sign-outs, not well thought through patients, and those things are going to be that's the type of a slip that would lead to an error, and easily lead to an error, and that might lead to more serious consequences for them, and certainly for their colleagues, and they may be, you know, shunned and maybe asked to leave, that kind of a thing. So knowing that that's ahead of them, I think, would be helpful.
I think that's a great point, and I think that we can also talk about the expectations that have shifted in our modern medical practice away from just, you know, you're the guy in the group who doesn't help out your fellow providers, and perhaps when you need something, we're not going to help you. That's the soft sort of banishment that occurs in the group. But now we've moved to a world where peer assessment of competence is driving people's reappointments and driving people's promotions. I don't know if that's occurring at your schools, but we certainly have multiple peer evaluations, peer assessments that have to be completed before we can go up for reappointment. And these are complicated forms that have lots of comments about just this sort of thing, this sign-out professionalism, completeness part of the package. It's the new rules and this new world order, and I think your grads, future grads need to know about those things. I think you're totally right. All right.
It's not just within academics, too.
Certainly, yeah.
You know, your medical director is going to figure this out pretty fast.
Yep.
And so, you know, residents need to have the understanding that they're jeopardizing their future career, their patient care with these types of behaviors.
Right. So the comment was your medical director can figure this out very quickly, that you can jeopardize your career. I think about it just like, you know, it's a third-year resident, right? It's often when their classmates become chief and begin making the schedule that this becomes a real problem, because their classmates will call them out on it for the first time in a formal way. And they start to get schedules that make them feel relegated to the unfair pile. All right, let's go to our final case. This is a first-year resident. They come to talk to you after they've received their milestone evaluations. And I think this is a really tough one for us to figure out as we're closing this session. They're getting average evaluation scores on new innovations, and despite being an intern, these average scores put them close to a graduation level, right? So we have faculty members who are using a milestone assessment form and getting them into the 3s and the 4s and sometimes the 5s as an intern. So they feel like they can't figure out what areas they need to focus on to be studying. They're concerned that they're going to fall behind because they don't actually know what they're not good at, right? So you raise this concern at faculty meeting. You say this intern is not getting feedback that's formative. They're just getting general, like, yes, you're doing great, like all of the other residents. Faculty, you're being sloppy and lazy, and you're not being discriminatory when you're filling out your feedback forms. And this is what your faculty say back to you. It takes too much time to fill out all of these evaluations, right? None of your faculty ever say that, correct? Never. I have to evaluate residents after every shift, program director, every shift. Do you know how hard that is? Every shift. I don't understand what all the levels mean. This is a real issue. As Jeremy brought up, how much time do you really have to explain the nuanced differences between a level 3 and a level 4 on subcompetency 21? It's tough, right? And it takes me forever to log into the system. Why can't there just be a link? So there is survey fatigue. There is an electronic IT hurdle that they have to jump to get this done at the end of a busy shift when they want to sign out and they want to go home and they want to have dinner, right? These are real concerns. I kind of mock them a little bit, but they're real concerns. So how do you address them? Frontal lobotomy.
So I think this is a lot of our problem in our evaluations, right?
Yep.
So we do not use new innovations or MedHub or whatever because of that very reason, and have taken great pains and a lot of iterations of our end of shift eval to keep refining it and keep changing it, and it keeps rolling out a new one after a new one after a new one, so that people are used to the process, they're used to doing it. So that part's done, but then refining the evaluation to make it much more user-friendly. And that, I think, for us has really driven actually getting back what we need. And when we don't get back what we need, we look at it and say, okay, how can we change it? How can we make this more user-friendly? And I think a reliance on new innovations, it's not going to get us there. It hasn't gotten us there in 5 years, and I don't see it changing. And so I think or taking milestones and reworking it with our very smart brains into a way that our faculty who have no training about milestones can interpret. That's the key, and that's what we have to do.
Absolutely, that's the correct answer. Your first response is to say they need a frontal lobotomy. I hate these faculty. Can't they just do their jobs? But perhaps this really is a challenge for very smart people who just simply can't get past these couple of important issues, right? And how do we make assessment something that's user-friendly and simple for them, but it's still rich enough that we're going to be able to gather the data in a bunch of different ways to be able to appropriately assess our residents? I think you're spot on. So who else has struggled with this? How have you changed your assessment models? You're not using MedHub or New Innovations. What are you using? Paper?
An amazing APD, Justin Stones, give him all the credit, who's created a QR system. So every single one of our residents has a QR code that links to a Google form, and all of that is collected in a Google form and then collated by one of our admins. And that has kept it much more user-friendly. We have one of our faculty members is here. I think it's much more user-friendly. It's much easier. It's much easier for us on the back end to collate all the information. It's much easier for us to change things on the fly as we need to change things. And I don't know, it's just worked really well for us.
Is it protected behind a firewall that?
It is not.
Okay.
I know.
I'm sorry, I called you out on that. Okay. Bad moderator. Other assessment changes, Carrie?
This is not necessarily an assessment change, but I would advocate for folks who are having this trouble to think about educational RVUs and how to use money, honestly, to help them with this problem. And if anybody needs help with such a system.
We have a few minutes for you to tell us how you did that.
I would need quite a bit longer than that, right? But the bottom line is that we do have a model at BMC that we use, and not every faculty member has to reach a certain quantity of evaluations, but that if they want to use evaluating residents as one of their educational RVUs, then they do need to meet.
So they can opt into the menu. And
right.
What can you tell us what your number is? Just a.
I don't have it off the top of my head. Sorry.
Don't have it off the top. And is it a different number for core faculty and
No, it's
No.
not. a
Same
different
for
number.
anybody who wants into the
Yes.
system. Interesting. Okay, thank you.
I don't want to turn this into a debate about educational overuse because I think they're very interesting, but I would ask, my concern about that, is there a qualitative component to it, or is it pure quantitative, right? Because, you know, you can pay, if you're just incentivizing to do numbers, if you're getting a whole bunch of crap, then it's still crap.
Yeah,
but if
junk
you're
in, junk
actually,
out.
if the system is designed to provide, and I think it speaks to the quality of the evaluative tool that you use, but there has to be, I think, some internal motivation amongst your faculty, too, in order to get that quality.
Totally agree. This is not the only answer. You have to give them a tool that's good to work with, that's going to give you the information that you want.
Yes.
I think this is a situation where the chair of the department might have to get involved and make clear to faculty that this is part of your job. This is what it means to be faculty. It's integral to it. And the feedback, whether you love the instrument or whether it's perfectly easy to use, we as a department can work on that. But this is part of your job, and this is one of the most important things, just as important as bedside immediate feedback. And it's not negotiable. You just have to do this.
Amen. If you can pick up your chair, bat phone, and call your other fellow chairs and tell them all that, I think everyone in the audience would be thrilled. But that's right. I mean, that would be wonderful if all the chairs actually.
I have a very strong program director that keeps me on a short leash.
Yes. All right, we're at the close of our session. Thank you guys for being participatory, both with your comments here in this discussion and then what you've been typing. The next steps are, if you'd like to have these comments collated and sent to you as a set of action items or handouts, we will summarize them in the next 2 weeks. So just make sure your name and email address is on the Google Docs form. We'll be happy to share that with you. I'd encourage you to start looking at some alternative models of curriculum design and competency-based assessment. Our team really likes Fink's taxonomy of significant learning as a way to complement CBME and to try to fill in all of the humanistic, human domain, caring domains that perhaps reductionism misses in CBME. And if you'd like a little further reading, I would look up Fink's taxonomy of significant learning. So with that, thank you guys very much. We're really grateful for your participation. Yeah, we'll put the cue back up. Yep. Thank you.